Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Kateryna. How are you doing today?
I'm good. I'm happy to see you.
Wonderful. SOMSA 25. We're doing it live here on the campus here. So welcome to the U.S. Welcome to SOMSA. You did a presentation yesterday. How did it go?
Yeah, we came here with John Queen, and we were working on a workshop, NATO lessons learned from Ukraine, and we were talking about our cases, the mistakes we did, owning those mistakes, and what would we change if we could. If we were magicians, if we could go back in time, and what would we do? So it went well, I guess. It would be awesome to share it on the bigger audience, because I think it's good to be able to say, we were trying our best, we still, did mistakes. Oh, also, can we say bad words here?
Sure, fire away.
We fucked it up, but then it's amazing to say, we did it, but we want to learn.
So during your presentation, what I think was a very good presentation, kind of the ultimate theme was doing the right things too late, you end up in the same spot, bad outcomes, right? So if you wouldn't mind, let's kind of rewind that case. Starting at POI, what were the injury patterns?
So on POI, the incident happened because of FPV drone explosion. So that's what happened in POI. The soldier got the injury of his right femur, upper end of it, and right buttock. So it looked like a huge, just a wound, which was bleeding. That's that. And that's it. Yeah. Oh, yeah. And he had a small wound on his abdomen from the right side. A small wound. Yeah.
Like a shrapnel
Nothing
penetration?
Special. Yeah.
Okay. So T-TRIC happened in whatever level and capacity it happened. One thing I've just seen from just the news and from other Ukrainians talking about it, it can be a long time between the actual injury and some kind of medical provider getting to him. So do you happen to know how long that took?
Yeah, so the incident that was happening in this region of Ukraine is very specific because this region of Ukraine, we talked that we have the ability to have POI very close to roll 3. Yeah. So in this region, the closest roll 3 to POI is in 82 kilometers, which is hour and a half or maybe 2 hours maximum from POI. So it's very cool. And in this situation, what happened, from POI, the injured got into roll 2 right away in 12 minutes. And it's almost unbelievable because it rarely happens in Ukraine. Yeah. So there was no self-aid, but there was a very good body aid, which was limited just to extrication and evacuation on Kateryna right away to roll 2 in 12 minutes. It's fantastic. If we talk about this case, this thing was very good. I mean, they could have done it better, putting a pelvic binder on him.
Do they even carry that stuff?
Not these guys, but we're trying to teach, and we're seeing that even if it's Kateryna, we want to teach people how to use AGTs because it's easy to use it, right? So just leave it there with CLS guys on Kateryna, but they will be able to put it on. It's nothing special about AGTs or pelvic binders.
Yeah, they definitely a nice wide band, so you could definitely use it as that. So in record time, 12 minutes between bang to now he's in roll 2, you would think you got at least our version of roll 2s. I have surgeons, I have anesthetist of some kind, generally they're able to do some kind of damage control surgery. Is it the same in this case?
We're trying to learn, whole Ukraine is trying to understand fully, what roll 1, roll 2 is, and the difference. And yes, usually what you can see if you go and visit that on roll 2s, they're trying to put surgeons and anesthesiologists, a good trauma team who can work on the casualty. There was a trauma team on that roll 2, but the question is, what are their what is their competence, because what we see now that not a lot of like actual surgeons, anesthesiologists, like physicians actually understand TCCC because they came from civilian life and there was no time for preparing. And what is special about Ukraine, we're very good in small, like we have good physicians in very narrow specializations. But when like the shit happens, like a full-scale war, you have to switch and go to the front line. You have to do like trauma care, and people should be taught how to do this. And not a lot of, not the majority has a good competence to work on trauma patient.
Okay. And I've seen it's kind of, I wouldn't say resistance, but reluctance or something, whatever verb you want to add to it. I'm a doctor. That's medic stuff.
That's a huge problem. I'm saying I'm fighting with some of the like physicians that I sometimes encounter because they're like, they say like, oh, that's the medic, but I'm a physician. I'm like, dude, you know less than they know. And I do believe that the majority of people that we prepare, if we take a good solid CMC guy and like general, physician you take from the civilian, hospital and ask them to do like care to the trauma casualty, this dude wouldn't do well. Like our new like combat medics who are taught right now, yes, it's too late. Like war started in 2014. Like we were doing our best, smaller, not very quickly, but we were teaching them. Mm-hmm. And right now, since the full-scale war, we are teaching, like we're trying to do it much more quicker. But I want to say that I do believe that combat medics and those guys that we teach, like combat paramedic stuff, like and road care, like I do believe that they have more knowledge and experience to give care, to provide care to trauma casualty than the, one like physician from civilian hospital, if you take it. Yeah.
So, I mean, from what I understand from this casualty, blood definitely really important for this guy. Ultimately, he's going to need some kind of damage control surgery to control whatever's bleeding inside his belly. Either the medic or the Role 2, did they have blood?
Yeah, like when we go over it like in detail, so basically on Role 2, they were kind of doing the right things, but they were missing the whole point. The massive bleeding wasn't stopped. Like they were giving him blood, yes. Like they were doing the paracentesis, like how do you call it? Diagnostic lavage, right? Yeah. Or they were like stabilizing his leg. They were doing the Kramer splint. But like the guy was still bleeding. So that's not the DCR, right? And that's the DCS. So they gave him almost 2.5 liters of like, there was a lyoplasm, there was a fresh frozen plasma, there was a red blood cells, there wasn't whole blood, but they gave him blood, but he was bleeding still. Yeah. And they decided to evacuate the unstable casualty. And what they did, they used vasopressors, which let them lie. They basically lied to themselves, gave him vasopressors, and decided that he's stable to be evacuated, but he wasn't.
And that's been a thing for a long time. I think, vasopressors, whether you're talking epi, norepi, or even calcium can give you that effect as well. They can make your numbers look great, but you're just shrinking vessels and you're not really perfusing the patient. So maybe a good bridge to get to like over there, maybe not like a good resuscitation type model. Component therapy, super common in US hospitals. They're starting to have some whole blood. I know probably most of the world has been like yelling like, hey, like whole blood is a thing. I guess why at a Role 2 would you have component therapy versus like whole blood?
Again, it's all about competence. What we teach, because I'm like TCCC instructor and we teach from like start CLS level and end with medical evacuation course, which is en route care, which is combat paramedic stuff. Yeah. And there we teach how do you do the blood transfusion. We teach do the blood far forward thing, like prepare. And we have like 400 students that we have taught since the full-scale war for combat paramedic. And these dudes, they use it. They use whole blood. They understand it. Like they see the numbers on the vitals are bad, and they go take the hemocon, get their blood, and it's all about the people who work on the Role do to understand that, oh, we have hemocons, we have people, we can fucking get the whole blood. That's what we did on roll 3. We gave him whole blood from my colleague. So we have people, but they are displaced in time and, and actual roles.
Yeah. So, and this is definitely not the first time I've ever heard anything like that, but it seems like there's a lot of miscommunication along the way.
For sure.
Is this like a Ukrainian Army versus Ukrainian Navy versus Ukrainian Air Force kind of problem, or is this just everybody's individual and you can go do what you think is best?
There is a phrase that John Quinn says about Ukraine that, like he said it in the beginning of the workshop, that like, remember that Ukraine is non-homogeneous zone, and it's true. And it's not only talking about territory, it's about people, skills, and stuff. And this could play well in some situations, but usually it creates problems that we like try as much as we possible to do everything standardized. But, people die, we teach them again, and it's constantly changing. Yeah, people are trying to do what they want to do.
Like a medical...
We see that the biggest problem comes like from highs and lows, right? But the biggest one, there is no medical evacuation, medical planning courses in Ukraine. They just turned out right now from John Quinn, our colleague from Europe, and Dennis Surkow. They started to provide actual medical planning courses to plan stuff so that this stuff doesn't happen, right? And we also see that there is also a problem with Moscow teachings, because a lot of such casualties become from red to very red to the black one. They become like this because of the lack of the Moscow skills, And so I was visiting here that class, and I'm like, oh, to do the Moscow, you still need to know how to do the basic plannings, like CMPAC thing. Yeah. You need to plan, right? So no planning. That's why good people with a good competence are in the wrong places, Yeah. If we would divide our team from role 3 and put it into role 2, so that might play better. Yeah.
Potentially.
Yeah. But we don't know.
There's only so many, there always is going to be just so many people that either no teach or I see, like you're good doctors or you're good medics, there's only going to be so many. Mm-hmm. How do you spread the wealth? How do you get people to understand? And the first trick is getting them to want to understand. And that's a human thing, I think.
And what I see, I do believe with my colleagues that yes, there is a problem from higher commanders and the lack of understanding of all of this stuff. Would I be a magician? I would take all of them and make them go do the CLS, CMC, medical evacuation course, then medical planning, then Moscow, then go and be a commander. And then things could change. But it's very rigid if you start changing from the higher highs, right? So for me and for my colleagues, it works better to just meet soldiers and be like, you need to learn, come to us. And, we just spread it from the lows and it actually works. Yeah. But also seeing our colleagues, the higher highs somewhere here, on such conferences, gives the chance to talk to them and be like, I know good classes and you guys would get a lot if you go and learn yourself and teach yourself and be try it and show the others commanders that it's, I did it. It actually helps. I have understanding. Now I know how I need to divide my people and whom I should put on role 2, whom I should put on role 2, on 1. Do we actually need a role 1 or we can switch to medical evacuation, fully,
Right.
It's all about studying and getting a good competence, but someone needs to be there and tell them, you don't know shit, you need to go. Teachers.
Yeah, absolutely. So you get to the role 2, and I absolutely understand you weren't there, but I guess why did they decide to do the procedures in the order that they did? Is that just what they do in civilian hospital, and they just defaulted to that?
I don't know who talked to you from Ukraine, and maybe I will do the wrong thing if I say it out loud right now, but I was studying in Canada, right? Yeah. And I know the education over there, and I have the idea what kind of education is here. It's difficult, it's expensive, it's long. But then what you have here and in Canada, that everyone ends up having like almost the same amount of knowledge. I mean, same basics, right? And in Ukraine, you get something to know something, you got to work on yourself. And the majority of my colleagues and friends that I know, that's what they did, you know, but it's my circle. Yeah. And 80% of, you know, physicians we have in Ukraine, I mean, they are good, but in the end of the day, they know just only their thing, you know. You talk about ophthalmologists, they just know the cataracts. You talk about like general surgeons in like civilian hospitals, they just know how to do appendicitis. Like that's that, you know? I mean, it's good if you like work in like civilian, like life without war, but if you're going there to military hospitals, to role 1, role 2, to frontline, you need to know the basics.
Yeah. So is there a pipeline? So let's say general civilian surgeon. Doctor. Is there some kind of pipeline of education? Pipeline is like when you went to medical school, like, hey, first you're going to learn all the vocabulary, and then you're going to learn this, and then you're going to learn that, and that's a pipeline. Just a pre-planned like set of things you will learn and do before we spit you out on the other side and now you go do.
When you get into to medical school, it's not easy to learn in our medical schools because we don't have good books. We don't have it like homogeneously. We don't have standardized, you know, number of books you need to learn to know this thing or that thing. I used to learn even like through Russian books. Like, can you imagine this from the library? We have in the library, like still Russian books. Like they already get rid of it like a few years ago, but when I was studying. Anyways, and then you finish it. It's not easy. You learn something, yes, but then you end up and then you go to residency and they have the plan on the paper, but it doesn't fucking exist in real life. You need to go on your own, learn who you want to teach from, learn from and ask that surgeon or anesthesiologist, please teach me. Yeah. And it's just my problem as a resident. Like I go and I look for the right person to teach me. And if I find it, he will. You want to pay, you pay. I don't know, you share but you need to get the knowledge and experience and skills. And that's how it actually works. Oh, okay. Yeah. I mean, everything is on paper, you know? Everything looks good. You're fine. It's not.
Not reality? Okay. So doesn't seem like there was any real decisions as far as what we're going to do. It's more like, this is what I know to do. I'll do that.
Yeah. But what we are trying to do, I mean, I understand from my personal point of view, what I will do learn from this situation. So I'm trying to get myself connected with commanders and higher guys who can actually see me in my face. So that's why, and it's not only about medical stuff, it's about everything regarding the rigid systems, you know, and that's why I'm trying to kind of stay civilian and be like, oh, I'm here in military stuff, but I'm not, you know, I have the ability to stay civilian but I will say things out loud. And also I'm trying to keep on teaching soldiers, and that's how we see effects. Maybe it's not that quick as possible, but that's why you teach instructors, right? Yeah,
absolutely. Absolutely.
That's how you can share the knowledge.
So it sounds like role 2 was kind of just a goat rope. We get him back from the role 2, I guess, how much time between him arriving at role 2 and him arriving at role 3?
So this is also why it happened. No one knows. No one gives the answers, but I can just only guess with my colleagues. So the distance from role 2 to role 3 is something like 50 kilometers or 40 something. So usually it takes 60 minutes maximum to drive from that role 2 to our role 3. But for some reason it took them 5 hours. So I just suspect that, you know, to compare the styles of work. So guys of his body aid was like scoop and run, right? And these dudes, I just suspect they decided to do plain stay. Yep. You know, something happened. He was just constantly going worse. And you know this thing, when you start to do something and then, wow, it's like 3 hours left, you know, are gone. So I guess that's what happened, because when he arrived to role 3, his like vitals were very close to these, but the much higher doses of vasopressors. Yeah.
I mean, it's, I think it's it sounds like, anyway, just a lack of understanding what damage control actually means. And, you know, hey, like, I'm a surgeon, I'm gonna complete the surgery, and then they'll continue on. It's what it sounds like. So that would definitely explain the hours it takes to...
That's what actually happened. Like, people were doing something, like surgeons were doing the surgical stuff, like anesthesiologists was kind of giving blood. Were they giving blood? Yeah. But the TCCC, the March thing, like, was still, you know, he was still bleeding. So that's why I'm saying, yeah, it's good. We have like cool organizations coming to Ukraine, teach us do like DCR and DCS. But if you take those who don't know the heck March is, like, how do you know, the language is different, right? Yeah. You know what I mean?
Yeah, you're absolutely right. Was there any kind of communication between role 3 and role 2?
Only that they stated that they have unstable casualty and they asked role 3 to evacuate.
Oh, okay. Yeah. So this wasn't until like 4 hours later? Or...
Yeah. Mm-hmm. Yeah. So basically he was bleeding out for 7 hours, you know, and we're talking about this like absolutely crazy thing that it was actually happening and it could be stopped right away from the beginning. And, you know, when I saw him in the morning at 9 a.m. and I was like, I saw the pattern of his injury and I saw his right leg and like his periton, like, anyways, it was bad. And I was like, we need reboa. Like right away. But no one was coming up about this, and I just brought 2 reboas to the place and I'm like, let's use it. And they were still hesitant. So yeah, but eventually we used it. And then when I looked back at it and I'm like, well, we could, even if we don't have reboa, let's get AGTs. Yeah. Right?
Yeah. Yeah.
Use AGT and scoop and run. Yeah. And that's it. And have blood.
Yeah, I mean, even if you essentially at that point put a knee in his belly.
You've done
or
your hand.
Fist or something like that.
Yeah.
There's kind of too many problems to, and there's so much that I don't know that it's like you almost, it's hard to figure out what the problem, because there's too many. The communications, it sounds like it was the biggest thing. And like, from like when I was Afghanistan, you know, I call up to the role 2 for evac, they're on their way. They understand like, hey, we're gonna do this much, and then we're gonna evac him to role 3. So they're gonna call ahead to let them know, hey, like, we are going to send somebody to you. You know, this is what we got initially. We'll tell you more as soon as we get eyes on. Something like that. Even if it was like, hey, I'm gonna give him a bath when he gets to the role 2, at least somebody else higher can tell you like, no, like, he doesn't need the bath right now. He actually needs this. You know, please start doing that and then evacuate him.
Yeah, like, you know, and we can pack it into one thing that should be created. Doesn't matter where you are. It's SOPs, standard operational procedures. Yeah. And when we teach our soldiers in our classes with All Ukrainian Resuscitation Council and Emergency Medicine, that's the team I'm working with, that we are like voluntarily teaching soldiers all of these levels. And we teach them, like day one, we teach them SOP. Yeah. And like first SOP, the perimeter is safe. The second SOP, like I do mescal, like triage. How many casualties do you have here? Second, like I'm working in the gloves. I'm thinking about my security. Then fourth one, like I look at the casualty, I take his, like I communicate with him and then I take his guns away and stuff and radio, and then I can work. But what we see now that we need to add this on top, like separately, communication with the team, with the casualty, with everyone around you, right? And that's about create SOPs regarding this, and also SOPs on when do you use AGTs? Like basically just a fucking list, short list, you know, score sheet that anyone can just check it and like, you know, look at the casualty and be like, and use this list and be like, I can use the AGT here.
Well, I mean, say the medics on the ground happen to have one, they throw it on the patient, he gets this role 2 with all the same people, all the same mindsets, he would still be dead because he's been essentially cut in half with this AHAT.
Yeah, that's true. And people need to know how long you can have it on, right? Yes, you can use partial occlusion, but I mean, like, it's very sad because, like, if I was a magician, I would do this, but I would teach those people. So all of these mistakes are done not because of they're reckless or they're doing this like on purpose, that they want to kill somebody. No, I do believe that they do the shit they like the best they can. Yes, you are a physician, but you don't know enough. But does this mean that you need to stop working and, leave? No. It means that look for the courses, look for the knowledge, for the competence that will let you be more confident anywhere, like on roll 1 or CASVAC, roll 1, roll 2, like medevac, whatever. Doesn't mean anything. Like, what do you actually mean? And what we see actually, we see that we need to if we universally teach as many combat medics as we can, we could move, like, because the tactical situation changes, right? Yeah. We need to be able to not be stuck and static. We need to be able to throw the roll 1 into the movable thing, because yes, a lot of people, a lot of my colleagues and Ukrainians say, we have a huge problem with evacuation. Yes, this is the fact. But it doesn't change the fact that DCR should be done in 1 hour from the point of view, right? And DCS should be done in 2 hours. You can't force the human body, the physiology of human body change. It's like, you gotta do something. So what do? You teach as many as possible CMC guys. At least you do DCR. You won't be able to do DCS. Yes, okay, fine. Or for DCS, you create more forward surgical groups, right?
So, I mean, it's easy to say they need more education. Like, yes, they are also, like, you're fixing the plane in flight.
Yeah.
They're still having to work. They're still going to get casualties.
That's what we have.
They're still going to go until they can't. I guess, how would you get in education while they're doing this?
Great question. Like, first of all, I would talk to commanders, show more cases that we don't have the luxury to lose everyone, but could we save them? Probably we could if we did the right things in the right time, not like 7 hours later. So these physicians, they always switch. They go to roll 1 or roll 2 for months or 3 weeks or 2 weeks, and then they go back to roll 3, and then, there is a constant and they work let's take this to roll 2. Not only, so on the roll 2, work people from different, brigades or like roll 3s or different places, So yes, for sure they have a different knowledge. But I mean, we can create the plan. So when they go back, like, let's create the class for them. Like, let's teach them. That's what I'm trying to do to talk to Riboa guys. I'm like, give me more of these and that's what I'm saying. I want to say it here for regarding anyone who's creating something to save life, like the equipment, because we also have the problem with equipment. It wasn't used on him because they didn't have it. And they didn't even know that it exists and what it does. But it's good to work governmentally, yes. But what happens, like, amazing stuff is given to the people who doesn't know what the heck is that. And then we happen to have the situation that amazing things like Riboa, GTs and, SCATCOs, like whatever, everything is sitting somewhere for years, not used. Right. And people who actually know how to use it know what is that. Like, they don't have it. So I'm like, okay, like, try to work from higher highs and also lower lows, learn somebody in person, know what they do, like, and that's what I'm saying about me. Like, I know people I know to whom I need to give it so that it's going to be used in the right hands, in the right places, in the right time, right? So we could create this. And for example, talking about, just about Riboa, right? So I'm like talking with these guys here and I'm like, could you give us also the mannequin so we could train while on roll 3, just, casually working, not under rockets, but still in the town, not close to the front lines. So it's all about the planning. Yeah. So, right? So you're saying very good thing that we're learning how to fly during the flight. And that's what we have. And what we see, why are we talking about medical planning at all? Because we plan when shit is already happened. Or after. So can that be solved? Yes, but.
Yeah, and hopefully somebody's writing this stuff down So you have lessons learned. So eventually, this conflict will end. Eventually. Will it be soon? I don't know. Will it be later? Probably. But eventually it will stop.
I mean, I want to say that this war turned us in very skeptics. And I mean, we all as humans need to understand that this world is very crazy and weird and unfair. And these wars gonna happen. Yep. Here and there. Hopefully this war ends in Ukraine. But Russia will not disappear. They will stay as our neighbor. Yeah. So we will need to be able to, to be ready for now, for the next 5 years or for 10 years. Yeah. Maybe not under active, rockets flying and active things happening, but people all around the world need to know that it can happen anywhere.
Absolutely. Yeah. And in all this, it's restated over and over in a bunch of different presentations, you can't create a competent whatever, during the emergency, after the emergency's already happened. It's generally too late. So all these lessons learned, super important, because hopefully it stays a lesson learned, not something we remember and then as soon as it's over we forget, and then we get to relearn the mistake after the fact. And I mean, this case is just a microcosm of something that's happening. How long is the front line? 4,000 kilometers? Again, this has been repeated probably hundreds and hundreds of times up and down that border. Yeah. So, definitely, God bless you as far as trying to educate and try to move things forward to save lives. But it's something that, if you're just working on this, role 3, role 2, role 1, it's got to also be spread to the others, So you definitely got your work cut out for you.
Yeah, I want to just summarize these lessons from this case, right? It's just points. So the first one, we already talked about competence. So the training, right? Yeah. So the training should be done, and it doesn't matter. Are you in Ukraine or here or anywhere? Don't wait for the shit to happen to train, right? You just train. Get ready. Then second one is the big one. It's communication. And we can talk about SOPs, standard operational procedures, and the communication wasn't done at all. And then medical planning wasn't done. So that's why all of this happened, that the wrong people were in the wrong place and the right people were too late. Yeah. Right? And I want to jump on quickly on one more thing, that we need to learn how to say, I don't know what to do. Let me look for help. And they could use telemedicine from the point of injury, and telemedicine is used. I mean, at least be able to say out loud, I don't know, but call somebody, show them the casualty and show them what the casualty has. And maybe someone going to give you the advice, use this. Yeah. You don't have pelvic binder, use his trousers to fix his pelvis, right? Yeah. So the communication and saying out loud that I don't know. And yes, of course, the equipment, when you don't have stuff, you can do stuff, but at least you need to know what you are looking for, right?
Yeah, absolutely. Like the whole telemedicine piece, just overcoming that hurdle of admitting you don't know what's going on, to then ask for help. That's the biggest part, is just recognizing you're out of your depth. Is there anything else that you'd like to chat about with this case?
Maybe just summarize about also the usage of RIBOA and AGTs. I talked with my colleague Eric, who's representing RIBOA, and he's like, we see this thing often happening, that people are hesitant to use it, and when they decide to use it when it's already too well. And there is the saying on the slides that, if you look at the casualty and you feel like they need it, they probably already need to have it. You don't have to inflate it, either AGT or RIBOA. You don't have to right away open it, right? But just if you feel like it should be there, so start with at least putting introducer in. You have introducer, you have the way you were to shoot the RIBOA. If you have the introducer in and you don't have RIBOA in your place, then ask for it, but they already have the introducer in, so it saves time. Yeah. So more SOPs on AGTs and RIBOA, and to be not that hesitant to use it. Yeah. Perfect. Despite the fact that it's very expensive, but still don't.
Yeah. And that always comes into it as well, eventually.
Sure. But yeah, I want to say just thank you for what you're doing, because you're helping a lot.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.